This is Dr. Craig, and welcome to Top 10 Radiology. Let's talk lung adenocarcinoma. So, the lung is staged the same way as breast and prostate cancer are with the TNM system. Similar to breast cancer, lung cancer T staging includes a size measurement. In this case, it's 3 centimeters is the cutoff you're looking for. Adjacent invasion into the chest wall or mediastinum separates T1 and 2 disease from T3 and 4 disease. Additionally, you want to note if there are any suspicious nodules in the same or other nodes. Regarding nodal staging, you're looking for ipsilateral versus contralateral lymph nodes within the mediastinum and hilum. It's actually worth distinguishing positive hilar nodes from mediastinal nodes. And then, and again, noting the contralateral aspect of things is a very important distinguisher in the nodal staging. Looking at metastatic sites, you're going to see liver and adrenal glands being by far the most common, and then the kidney, bone, and CNS. At our institution, they do chest and abdomen studies, and that's kind of a nice way to think about the location of these METs, because essentially that scan will cover the most common metastatic sites outside of the brain. Regarding complications, you're going to be thinking mostly in the lungs. So pneumonia, think about like a post-obstructive if something's blocking an airway and then that airway starts filling up with bacteria. ARDS, PE, pulmonary edema, and MI. I'm not exactly sure how DIC would show up on your scan, but I'm sure that would be in the clinical history if you're lucky. Again, with PE and with all cancer studies, PE is very often overlooked, and you just kind of have to add it to your reading pattern and make sure you window hard on it. The pearls of lung adenocarcinoma include asymmetric diaphragm elevation. That's going to tell you that it's laryngeal nerve involvement. That's T4 guaranteed. So look on your coronal images for that. And then again, these kind of follow patterns. So in this case, the presence of liver mets correlated with the presence of kidney and pancreatic mets. I personally have never seen a pancreatic metastatic lesion from lung cancer, but I guess I don't read lung cancer studies all the time. Whenever I think of pancreatic mets, I think of RCC.
Okay, so this is our first case of lung adenocarcinoma. I chose this one not because of necessarily metastatic disease or discussing it, but just the appearance of it is really a great case. This is a woman in her late 30s, and what you see here as we come up is you're going to see this pretty large ground glass opacity measuring 2.6 centimeters. And what you'll see in the center there is a certain degree of solid tissue. And so this is one of those slow growing lung adenocarcinomas that just kind of start as filling up the alveoli with lung cancer or with cancerous cells, and then it slowly kind of accumulates and becomes this solid tissue here. And so if I was evaluating this, I would do the measurement as I just did. And then next stop is to look for any type of lymph nodes. I want to focus here at supraclavicular lymph nodes because these are, I believe, T4 disease at that point. So it's kind of important to focus on that region. And then as I go down, I'm looking at the hilum or the mediastinum, and this, in theory, the measurements made per the ACR white paper criteria last year that came out said that mediastinal lymphadenopathy is considered 1.5 centimeters. So this in short axis diameter, and this doesn't meet that. But one other thing, so I don't see any mediastinal lymphadenopathy. Looking at the other side, because that's a completely different stage. And then I want to look for that subcarinal guy, which he's nice and flat. That one's typically a lot bigger than the other guys, but he's only about, maybe about 5 millimeters. And so what we're doing is the one tricky thing that I had a really hard time evaluating when I was in residency was looking at this perihilar node and this little pancake guy here. So in this case, this guy looks a little bit enlarged, about 1 centimeter in size. And while it doesn't meet that size criteria for lymphadenopathy, in this case, I would certainly always always report anything that just looks a little bit abnormal or a little bit prominent, because in this case, the person could read my report and potentially make the decision to biopsy based on that. So if I'm looking here, I want to look for other nodules within the lung, because that's also considered T4. I see that one, not really that important. And this is, it's not large, it's not really spiculated. It doesn't really have that appearance of a worrisome for metastatic focus. And then you see these guys, this is kind of a triangular shaped subpleural nodule that's associated with the major fissure. And in this case, anytime you see like a lymph node or a nodule that is associated with the major fissure or minor fissure that is triangular in shape or kind of quadrilateral, then you can think it's a fissural lymph node. I don't see anything here. Quick view. Of course, I would do this a lot slower if I was to evaluate this. And next, I want to go down into the top of the abdomen. As mentioned before, the number 1 and number 2 metastatic sites are the liver and the the adrenal glands. And so in this case, I'm going to be closely evaluating the adrenal glands for anything abnormal. And then looking up here at the liver, this is likely fat because it doesn't really have mass effect. It's just kind of following it despite the fact it's low attenuation. And then quickly view. And then again, the liver windows helps point for anything really, makes anything really big stand out. And so in this case, I see a little ditzel right there in segment 2 that's kind of non-specific. Can't really tell you. I would say in this case, too small to characterize, but still report it. Okay, let's look at our second case of lung adenocarcinoma. What I'm seeing here is I'm going down and I see this kind of perihilar or perimediastinal mass that really has a strong interface between, or a long interface between the lesion itself and the mediastinum. And it looks like it's really just directly extending into the mediastinum. And so that's going to put it in a different category other than just size. And now I would want to evaluate, just because the size of this thing, I'd be a little bit suspicious for other malignancies within the lung. And as I look here, I see this tiny little 3 millimeter nodule in the left upper lobe that I would certainly report. And they did report it in their evaluation of it, the chest folk here at the University of Colorado. So next I want to evaluate for lymphadenopathy. And as you can tell, immediately you can see that there are just abnormal lymph nodes on the contralateral side of the upper trachea here. So that's, and as well as the subcarinal location is just kind of a conglomerate of abnormal appearing lymph nodes here. If I look more closely in the hilum, which you kind of have to do every once in a while, is you'd see this abnormal appearing perihilar node. And so based on this, we have contralateral nodal disease here. And so again, this is the first time this patient's coming in, so I would be a little bit cautious based on the degree of spread here that this person's going to have metastatic disease. I want to do a quick view of the pulmonary arteries again. While there isn't, this isn't great evaluation for a pulmonary embolus, you could catch kind of the larger central or lobar lesions here. Now looking in the thorax, immediately I look at the Y-shaped adrenal glands here, and then something should be catching your eye. There's all these rim-enhancing metastatic lesions throughout the liver. They really kind of pop out with that liver window. So that's essentially why we do it. So this person has definite metastatic disease to the liver. And then lastly, while we're still here, we can look at the bones. Again, my search pattern is looking coronal at all the ribs. I'm trying to look at the straight aspects of every rib here, which I don't see anything. And then going down, my favorite view is the sagittal. I don't see much. The sternum looks like it's been a little trauma there in the past. This is degenerative change, as you can tell by the vacuum disc phenomenon and kind of opposing in place sclerosis there. So I'm not really worried about a MET. They have dish here, but I don't necessarily see any bone lesions here. Looking on the other side, nothing here. So this is a pretty good pattern of disease, considering we have the liver metastases as well as the contralateral node disease.